What's up, everyone? We're back with another Season 2 PITT reaction video. This time it's episode 7. For those that are new here, my name's Hunter. I'm a first-year emergency medicine resident in Minnesota, so I'm basically Whitaker. Let's get into it.
I have a sexual assault victim in triage. I called PAR, so an advocate is on the way.
Okay, we'll take care of it.
Your debrief is lovely.
Thank you. Would you mind helping Dana with the sexual assault victim who just came in?
Of course, sure.
Why don't you and I go see if we can't convince your patient to leave?
All right, I need to take care of a sexual assault victim in triage. One of you needs to hold down the fort.
We can call for a sane.
On a holiday? It'd be ours. We're not going to make this patient wait. And since I'm the only sane on staff...
A SANE is a sexual assault nurse examiner. There are very intimate exams that go into a physical exam after a sexual assault is done. And in the emergency department, there is a way for evidence to be collected. There's clothing that is collected, as well as swabs from various areas of the body for DNA collection. And it all has to be done in a very controlled process, as it is part of a forensics kit that is then used in lawsuits, cases, things like that. So there are specially trained nurses to do these exams, and that is what SANE is referring to in this case.
You ready, Doc? Sure. A sane is a sexual assault nurse examiner. We do forensic exams, collect evidence, and hand it over to the police if a report is made. We also provide resources, support, sometimes even testimony.
You go to court?
Saints are very valuable in a hospital, especially in ED. More nurses should train for it.
It's as almost if I just said that.
Hi, Miss Miller. I'm Dana. How are you doing?
Been better.
Yeah. You're in a safe place now. I'm the charge nurse in the ED and a sexual assault nurse examiner. This is Emma. I'll be assisting.
And I'm Dr. Al-Hashimi. I'll be checking you for any injuries that need immediate attention.
You can just call me Alana. I don't have any injuries.
Okay, that's good.
We're going to get a room ready for you. Meanwhile, Dr. Al-Hashimi's going to ask you a few questions.
How long is this going to take?
I can't promise an exact time, but we'll try to be as fast as you need.
Thank you.
Yeah.
I always talk about how one of the things that I enjoy about emergency medicine is how we get to see patients when they are frequently at one of the most vulnerable points in their life, whether it was after an injury or with a severe illness. And I take great pride in the empathy that I show for patients and my humanistic skills, my bedside manner. But it's really important that we recognize that, and that every patient we see can be having a horrible day. But especially in these cases of sexual assault, we also see domestic violence and other assault victims in the emergency department, and they are in a very traumatic situation, just having been assaulted, but also now having to share the details of those things with multiple people. Usually we try to conduct these exams as a group, but with as few people as possible, so that the patient only has to tell their story one time to one person or a few people, so that we can have everything that we need to document things in case a report is filed and they want to go to court with it. And it just protects the patient so that they're not re-experiencing this event over and over as they tell it to a bunch of different people. And so I think it's just good to recognize that the emergency department is a place for very vulnerable encounters, and it's our responsibility to make these as comfortable as they can be for the patients.
Dr. Ellis.
Oh, no.
Oh, yes. Need the room. Find another place to lay your head.
Not even a 20-minute power nap? And my double's at 1:30. I'm
No,
tired.
we're getting Westbridge diversions. And chairs is insane. Didn't you see out there?
Ew, I did not come in through that mess.
Okay. Yeah.
People sleep in here?
Yeah, night shift doctors need rest, especially if they have to come in during the day. But today we can't waste the space.
I think that every hospital on the face of the earth has a call room that physicians can sleep in if they need to. I've never heard of someone sleeping in a patient room or triage room in the emergency department. That is pretty absurd.
So you're having a headache and abdominal pain?
Yeah, that's right.
Okay, and which would you say is worse?
My headache was terrible last week, but now...
Hey, you're breaking up. Can you run that back again?
Sure. My headache was terrible last week, but now my abdominal pain... Oh.
God, come on, you piece of shit. Fuck. I'll be right back. Sorry.
Okay, so this is just like a very poor practice of medicine. First, I know we talked about it in the last episode that this patient is deaf and needs an American Sign Language interpreter to be able to communicate. It's very clear here that she can at least read, and I would guess can write as well. So I think that that would be a great alternative form of communication since they're having trouble getting an interpreter to be able to do a proper history. But this is a woman of childbearing age, and I would definitely want to get a pregnancy test in her before we decided to jump to a CT because the radiation could be detrimental to a fetus, and a headache with abdominal pain, I mean, she very well could be pregnant. So that's definitely something that I would want to rule out. But I said it last episode, I don't like how they are just dismissing this patient simply because they can't communicate with her. You can communicate in very different forms. I mean, I don't know American Sign Language. Charades could work, but also just pen and paper, try to do an exam. I mean, it's hard to communicate that you want to do an exam and get consent to do an exam because you should do that on every patient. But at least by doing a physical exam, you can try to gauge what exactly their symptoms are and then make a plan. You don't just get a CT just to be safe.
Mr. and Mrs. Davis, this is one of my attendings, Dr. Al-Hashimi.
Hi, nice to meet you. Demi.
Charles, what the hell's going on? He's barely conscious.
Jackson's just a little tired due to the sedative he was given. You sedated him.
Oh, your son was brought in extremely agitated.
You'd be too if you were tased.
And why the fuck did they do that? This is bullshit. We're taking him home.
Why don't we step out for a second? Right now, Jackson is on an involuntary psych hold.
What? That's not necessary.
He just needs some rest. He's been studying for the bar exam. We can watch him at home.
So far, all of his tests look good, but Jackson has reported hearing voices. This could be serious.
Dr. Jefferson will come back and speak with you. He can explain more of what may be going on with Jackson.
And who is Dr. Jefferson?
He's from psychiatry, and he's excellent. He can explain next steps and answer all of your questions.
Javadi, why don't you take the Davises to the family room?
Sure. Excuse me. It's just this way.
I think that was very appropriate in this situation. You could tell that the tensions within the room were rising, and the parents needed to be informed of what the entire situation was that was going on, but it's best to do that in a more controlled environment and not let tempers and emotions flare in the room with the patient.
Hi, this is Dr. Baran Al-Hashimi. I'm a patient of Dr. Fairgraves. I need to speak to him if he's on call. If he's not, I'll take his next available appointment. And please call me if he has a cancellation. Thank you.
It feels like there's always something going on with these physicians. In the last season, I forget the name of the doctor, but it seemed that she was pregnant and had a pregnancy loss. And we are all humans as physicians in the department. We are all dealing with our own things as well. And it seems that Dr. Al-Hashimi has some sort of cognitive diagnosis that she sees a neuroscientist for. So that'll be an interesting thing to discover, I guess.
Stay down here until an inpatient bed opens up upstairs, but that can take a while. Sometimes days, even longer.
It's gonna be really noisy here and you won't get any rest. At home, you'll be surrounded by your family and be more comfortable.
It's your choice, Roxy. It's not that I don't want to go home, but...
Hi, Mom.
Mom!
Lena texted me to come back. I figured I'd bring the boys. What's going on? Is everything okay?
Robbie, police officer, incoming trauma.
Coming. I'll be right back. We'll give you a chance to talk.
That was extremely inappropriate. I mean, I get that Dr. Robbie has his own motivations for getting people out of the hospital and trying to open up beds for the other people that they have coming in, but they basically just tried to strong-arm this patient's decision to stay versus go home simply for their own motivational gains. I think having a shared decision-making discussion involves laying out all of the options, the risks and benefits of both, and not putting your own bias into that conversation to try and make the patient make the decision that you want them to make.
Intubated neck wounds. That's not great. We were diverted here. Is there a trauma room open?
Trauma 1.
What's the story? My buddy, Officer Hero, high velocity GSW. He's getting harder to bag. Warehouse robbery gone sideways.
1, 2, 3.
You guys wait here. We'll take care of him, I promise. Thought you left us already for the open road.
I miss seeing you in uniform.
You should see me as a flight attendant.
Do you do this intubation?
Under active fire, yeah.
Are you serious?
I go in with the team in case there's an injury.
It's badass.
Dr. Santos, let's make sure these lungs are up. Can you see the cords?
Yeah, it was a great view, but it was hard to pass after I cleared him.
Yes, that's only 85.
Dr. Santos, what could cause respiratory failure in an intubated patient?
There are a lot of possibilities.
Think dope.
Displacement, obstruction, pneumothorax, equipment failure, good lung sliding, no pneumo.
It is displacement. Okay, that is a transected trachea.
Pulling out. Bag.
But if you intubate again, won't it just come straight out the wound?
Yep, exactly. So we're gonna need another plan.
Yeah.
Okay.
So that's down to 83.
Yeah, he's not moving in the air. Okay, I need a neonatal mask.
Neonatal?
Yep.
So that was one of the doctors from the previous season that was kind of showing a lot of signs of burnout in the later episodes. But one of the, I would say, lesser known subspecialties of emergency medicine is called tactical emergency medical services, where a emergency medicine physician deploys with usually like SWAT teams or other tactical police forces and is on site for when they are carrying out very high risk operations. And should any suspect or team member get injured, the physician is there to assess and treat as needed. And in this case, we had a difficult intubation due to neck trauma. And I feel like this would have probably been caught in the field. I know that they were probably putting force on the neck to stop any bleeding that was happening, but as soon as they deploy the balloon, there you would feel that and know that the tube is not in the correct place. And in an emergent situation right there, they would just do a crike or a cricothyrotomy where they go in through the neck to put a tube down into the trachea. And obviously the trachea was disrupted in that area, but in this case, definitive airway is all that matters. So getting a ET tube into the trachea to supply air to the lungs, doesn't matter how they do it. They wouldn't have made it this far with a doctor, an emergency medicine physician, doing that airway.
Where does it hurt?
Like here, under my belly button.
Okay, do you have any fever, vomiting, diarrhea?
No, it's just stomach ache.
Okay, well, still go see the nurse and have her call me.
Okay. But I'm still having ice cream tonight.
Let's just see how you feel later.
It's not bad. You don't have to get so sad.
I'm not sad, I'm good.
Your face doesn't look good.
Well, do you still want to watch the fireworks tonight? I have our headphones.
I'm not being rude.
Sorry, Becca, I gotta go.
Sorry.
We sometimes have to deal with personal issues on shift, but 2 residents in the ambulance bay on their phones for personal conversations, that never happens. I usually don't use my phone for anything except for with our electronic medical record. We have an app that we can use our phone to securely put images into the chart of the patient. Never goes across our own photo library. It just goes straight from the camera into the chart. And I will bring my phone into patient rooms to be able to document different, wounds, lacerations, rashes, things that it would be nice to be able to see a picture of rather than just my verbal description of it. But otherwise, my phone is staying in my pocket for most of my shift. My wife can attest that I will go 9 hours without responding to a text, even if she seemingly needs help. She knows to call if she really needs me. But yeah, I would say we don't typically have the time to do this, especially for how busy they are. I don't know. A little interesting there.
17 Syncopal episode of football practice.
Look, I just got dizzy.
17-year-old that passed out at football practice, he has HOCM, hypertrophic obstructive cardiomyopathy. It's where the septum of the heart is too large. It's a congenital thing that just happens, common in boys, and usually it's a teenage, younger male exercising that passes out. It is a problem, and he needs to be assessed.
Okay, it's hell week. I need to get back.
Yeah, okay, tough guy. ANO, systolic of 95, tachy at 122, no meds, no allergies.
How long were you at practice?
Started at 9, so like 4 hours.
4 hours in this heat with all that gear?
No pain, no game.
Could be heat shock too. There's other things on the differential, but HOCM is at the top.
Hey, when's our break?
There's no breaks down here. Always make sure you pack a protein bar, something quick.
Ogilvy, Joy.
That's funny. That's what I tell every med student that comes through the ER. I never pack a lunch or a dinner for any of my shifts. I just have a couple of snacks because you just have to plan that you're not going to have time to eat and just snack when you can. A bite of a protein bar here or there. My favorites are these first form ones. You can get them at the link in the description.
Possible heat stroke?
Well, with heat stroke, you would have an altered mental status.
And they're usually dry, not sweaty. Mortality is 50%, especially in the elderly. In extreme heat like this?
Ogilvy does not need to be throwing these stats out.
Orlando, where are you going?
Home. You take these out?
No, it takes 48 hours for you to get out of DKA. Your blood is still full of acid.
Look, I can't add thousands of dollars to the $100 grand I already owe.
I'm sorry, 100 grand?
It's a medical debt. My wife doesn't even know. I'll never be able to pay it off as it is.
How about this? You stay and I'll get together everything you'll need at home. Also, a referral to Northside Christian Health Center. Come on. You don't work until 4. It'll keep you from passing out on the job again. Or worse.
Okay, I guess.
Great. Thank you.
It's unfortunate that we are needing to resort to bargaining tactics to get patients to stay and get the care that they absolutely need. It's very frustrating.
Santos, finish the test.
Yeah, what are you injecting?
Lido with epi. It'll clamp off any little bleeders.
Some skin hooks. For Shiley?
I don't like the curve of a Shiley.
I didn't know you were so picky.
Santos, take a break. Help me cut down a 6-0 ET2.
What is going on here? You have a field...
A Shiley is a type of tracheostomy tube that is commonly used.
Hero here is in bad need of an airway. They cut it right here.
We can do this.
No, I got it. You must be Gloria's new hire.
Yes, Dr. Al-Hashimi.
Well, I'd shake your hand, but my tube is ready.
And if I could find and secure the distant trachea, we have a shot at this.
Okay, keeping an eye on the stats.
Slow is smooth is fast.
You know, you can call me just to say hi sometimes. What's up now?
GSW with tracheal transection.
Very retracted, but I think I can get it.
Both lungs are up?
Sats standing the belly now.
Okay, I got it. Gently, gently, or we're gonna lose it.
Down to 89.
I'm in, balloon up.
The trachea has these cartilaginous rings around it, so it wouldn't, I mean, it can, if it were fully transected, it would get sucked down into the mediastinum, into the chest, and you would have to go looking for it. But when you pulled it out, it would just be a very rigid tube that would be pulled up. It wouldn't stretch out in the way that he showed there. But as I said, they just needed to get tube into the trachea to get this guy some air. I also did appreciate that Dr. Santos recognized that there was other things that she could be doing since these two attendings were going to be doing the airway. And so grabbing the ultrasound to evaluate for free fluid in the abdomen was a great use of her as a resource.
While you were playing him with that airway, you missed a big bruise in the left upper quadrant. He was wearing body armor.
High velocity projectile doesn't have to penetrate to do damage.
There's no fluid in the suprasplenic space.
Let me look. Okay, right there.
Looks like a subcapsular hematoma of the spleen.
Must have been a big impact.
AR-15 muzzle velocity is 3,000 feet per second.
CT angio of the neck ASAP, along with CT chest, abdomen, pelvis.
Yep. Just as soon as we secure this tube.
There were a couple other things that they probably should have done in that case. Yes, this guy needs to get to the scanner so that they can evaluate all of his injuries. I definitely spaced out when EMS was reporting the blood pressure and heart rate for this patient. I'm guessing they're stable because they're going to the CT scanner. But then I also didn't hear any indication that they used medications to intubate this patient in the field. And so they should be doing a neurologic assessment because he shouldn't actually be comatose while they're doing all of this if they didn't give him a sedative and paralytic. So just a little bit of we discussed last week, airway, they got it. Breathing, he had lung sliding on both sides, lung sounds on both sides. Circulation, we're assuming at this point that his blood pressure and heart rate are stable, meaning that he hasn't had so much blood loss that his body is having to compensate for it. But then we get to disability, where we should be assessing the neurologic status of the patient, and then exposure, they kind of found that bruise, make sure that we're seeing the entire body and not missing any other injuries before we go to the scanner.
Pupils 4 millimeters reactive.
Did you get tackled today?
No, just running drills.
Any chest pain, palpitations?
No.
Hands off, please. Running the 12 lead.
How we looking?
Good. Healthy kid. No history, no trauma.
Differential for syncope in an adolescent.
Cardiac arrhythmia from drugs,
Hypovolemia,
long
seizure,
QT, WPW,
sepsis.
or Brugada.
Brugada is more common in Asian males.
But still should be considered.
Long odds, sir. Brugada prevalence is 1 in 20,000 in North America, as high as 1 in 300 in Asia and the Middle East.
And?
First described in 1992, has a high incidence of sudden death among young patients with otherwise structurally normal hearts.
Wait, did you just
get owned, Ogilvy?
2.5.
Sorry, our student doctors are discussing a rare condition you don't have.
Neck angio is negative, missed the carotids.
It's lucky.
What about the belly?
Small splenic injury, no free fluid in the abdomen.
That should heal on its own.
Let's plan.
Head and neck, we'll have an OR ready with thoracic standing by.
How soon can they take him?
We're a little backed up with Westbridge patients, but let's bring them up. I'll get them taken care of for you.
Hey, you're gonna be okay here. We're getting you to surgery.
I'll write the procedure note.
Thank you.
So you saw there that the patient did have his eyes open and was responsive to their conversation, but I would have liked to hear about that prior to going to the CT scanner.
Oh, there she is. Vic!
Dad.
Victoria, this is Dr. Amy June.
Hi, are you here to see a patient?
No, we're here to see you. Dr. June is chief of dermatology.
Let's grab a coffee sometime.
Absolutely, yes, thank you. You know Mom really wants me to go into surgery.
Your mom wants me to stop drinking and join a pickleball league.
Oh, that's the same.
Yeah, well,
exact same.
I will risk an Achilles tear before I give up scotch. Hey, I hope I didn't embarrass you coming down here.
No.
I'm just trying to present you with some options for your residency.
I really appreciate it, Dad. I do. I'm still not sure.
Well, either way, you'll do what's right. You always do. Radia.
Dr. Javadi, you are a man of many talents.
You don't know the half of it.
I think that Javadi is going to end up in emergency medicine. She seems to fit in well with the group here. But I think what we're seeing here is a good portrayal of the kind of influence in medicine that is quite common. I mean, I came through as a first-generation college student and didn't really have anyone in medicine in my family, so there wasn't really a whole lot of influence into what I ended up doing. But it is quite common that medical students have parents that are in medicine, or they just come from families that are very well attuned with the medical fields and have very high aspirations for their children and have expectations of them to go into specific specialties. And that can put a lot of pressure on these students who are already under a lot of pressure to perform well on these rotations and in school as a whole. And I think that this scene kind of just illustrates some of that tension and added pressure that can come from family when it's already a very stressful scenario for these med students.
Mr. and Mrs. Davis, this is Dr. Jefferson from psychiatry.
Please call me Caleb.
Can you tell us what's going on with our son?
All of his labs and x-rays came back normal, given his age and his hearing voices. Do either of you have a family history of mental illness?
Not mine.
My brother took his own life.
Wait, what? Uncle Ken? He said he drank himself to death. Why?
He did that too.
Was he ever formally diagnosed with a mental health issue?
No, he was depressed, had mood swings, but he didn't want to see anyone.
Oh my God. Okay, why am I just now hearing about this?
Jada, please.
Please what? Mom? Why would you not tell Jackson? Or me? I can't believe this.
Jada.
Excuse me.
Jada. What happens next?
We keep your son here for the next 3 days for observation and therapy, and that'll help us to understand what is going on.
Jada should really hear this. Let me see if I can find her.
The PITT does a really good job of hitting the very high yield topics, concepts, things that happen in emergency medicine. And I think right here is a great example of the stigma around mental health and talking about mental health, to the point that family members are lying to each other about mental health rather than bringing it to the forefront and discussing it and making sure that everyone is okay from a mental health standpoint. If you're enjoying this style of content, you might also enjoy the weekly vlogs that I put out every Sunday. I've been documenting my journey through residency since orientation, so before the first day, and I post every week about my experiences. So I have a playlist linked in the description below if you want to check it out.
That's it.
We have to honor your wife's wishes.
Even if she's loaded up with morphine and can't think straight?
Especially then. Hello?
Paul Hamler, this is my attending, Dr. Rubinovich.
Hi. My wife is not thinking clearly.
What is it that she's asking for?
It's that she wants to stay here.
Why don't we all go in and talk?
Brian Jenkins is allowed to hunt with a 20.
We've discussed in this patient case in previous episodes how it's very important to honor patient's wishes. And here the husband is alleging that the patient is not in the right state of mind to be making decisions. And us as physicians are required to figure out whether a patient has the mental capacity to make decisions for themselves. And so they need to determine that the patient understands the risks and benefits of both situations, can voice their understanding of those risks and benefits, and also indicate a decision one way or another. And if they can meet those things, then they can make their own medical decisions. And we run into this frequently where patients might have wishes that don't align with what the family wants, but we honor the patient's wishes in all circumstances. And sometimes, I don't foresee it going that far with this patient, but sometimes we need to have ethics committees weigh in on the decision around a patient's care, because whatever the family wants doesn't align with what the patient would have wanted, and they can't speak for themselves. And so we get into these very hairy decision-making processes, and we need outside resources to help with that.
How are we doing in here, Roxy?
Been better?
Rumor has it you're still interested in booking a room with us.
I don't want to go back home yet.
It's all set up, Rox. You're gonna be more comfortable at home.
Paul, I changed my mind. It is our home. I don't want you living with my ghost.
I will happily live with your ghost.
Can we just all stop talking about ghosts, please?
Yes, I'm sorry. Sorry, sweetie, you're right.
Got trauma flying in, ETA 5 minutes.
Okay, I'm very sorry. I will be right back. Excuse me.
It's a boating accident, swimmer versus propeller.
Ouch. What body parts involved?
They didn't say.
How old?
Nope.
Anything?
All I got was boating accident, swimmer versus propeller.
Propeller. Got it.
Typically, these notifications are paged overhead or via, we have a small, it's like a walkie-talkie device called a Vocera, where they can broadcast to all of the workers in the department and tell people about these things so that you don't have to interrupt possibly sensitive conversations. So I do find it interesting that they are always coming into the room to interrupt him to let him know that a trauma's coming in. Apologies for my dog barking in the back.
Okay, I'm just gonna say it. I'm sorry. I betrayed your trust. I betrayed our patient's trust. And I'm really fucking sorry. It'll never happen again, I swear.
I'm really glad that you got the help that you need. But I don't know if I want you working in my ER.
He was in the Allegheny trying to untangle a water ski tow line when his buddy started the engine.
Drunk buddy, I assume?
It's 4th of July, you tell me.
Focus on the patient, please. Sophie, take over baggie. 1, 2, 3. Watch that buckle.
You need me in here?
Nope. We have a senior resident and an attending.
Mel, can we start with
EFAS, sure.
yes, please. Why?
To check and make sure there's no pneumothorax, otherwise it could become a tension.
Exactly. Oh. You want ONEG?
Not without a BP first.
108/64, pulse is 102, sats are good.
Okay, let's have ONEG ready, but don't give it just yet.
Anything else?
How about a hemocube?
Yeah, of course.
It's very clear that the tension between Dr. Robbie and Dr. Langdon is now affecting patient care. And so, I mean, perhaps on the helipad was not the best place to try to address their beef. But also, I wanted to say that I have never seen doctors from the ED go to the helipad to receive a patient. They're not going to be doing anything from like an intervention standpoint. So we are typically just waiting for the arrival in our trauma bays. They'll bring them down through the elevator and we'll get report. But I don't really see the need to take two physicians out of the emergency department up to the helipad when they're really not going to be doing any interventions between the helipad and the department.
Hi, I'm Paulette Sanderson from Pittsburgh Action Against Rape.
Hi, Paulette. I'm the same Dane, and this is Alana.
Hello. I'm sorry to meet you under these circumstances, but I and my organization are here to help you navigate everything that comes next. I brought you some clothes and basic necessities. I can even stay with you through the rest of your examination if you'd like.
I don't think that's necessary.
That's fine. Would it be okay if I ask you a few questions?
Sure.
I'm not sure if it was supposed to be meant in this way, but it seemed like Dana was wanting to reach out to touch the patient to kind of offer her support. But it is important that we acknowledge in these situations that through a traumatic assault situation, simply touching a patient without their consent or without their expectation of you to do so could be another very traumatic thing for them. And so I think Dana thought about it and pulled back, recognizing the situation, but I might be just reading into that too much. I don't know.
What's this?
Daniel Scott, 32, weakened dizzy while washing his car, tachy at 106, BP 90/60, temps too high to register.
We have a cooling room set up in North 5.
Okay, how you feeling, Mr. Scott?
Thirsty.
Let's see if we can't fix that. He's gonna need a core temp, a CMP. Whoa.
Oh, hey, we need a trauma room. What's open? 2.
I'll grab the Ativan.
Any past medical history?
No, watch says he's healthy. No meds, no allergies.
He needs a core temp.
1, 2, 3.
Orders? Second IV with saline open, sepsis panel, UA, urine drug screen, EKG, and CK.
I don't see any apparent trauma.
Pupils reactive. Mr. Scott, Daniel, can you talk to me? Post-ictal, but moving all extremities.
Pulse 137, BP 88/60.
What are you thinking, Dr. Santos?
Heat stroke, but consider sepsis or drugs.
Rectal temp is 104.6.
62 was gathering the makings of a salad when he started feeling dizzy and nauseated, vomited once.
How you feeling, Mr. Stills?
I'm gonna die.
Well, you came to the right place to prevent that. Do you mind if I touch your abdomen?
Yeah, sure.
Does this hurt at all?
No. He's tachycardic at 124 with a temp of 102.4.
Hey, Joy, what's your suggestion?
Keep hydrating, check electrolytes, and move him to the cooling room.
Precisely. Good luck finding a parking spot.
North 5.
What? No valet?
I think they've done a pretty good job of showing that, yes, it's hot out, and the greatest suspicion is that all of these people are suffering from heat-related illness, whether it be dehydration, heat shock, heat stroke. But it's important to keep other things on the differential because some things can happen at the same time as other things, and some things look like one thing when they are in fact another. So it's just important that they're fully assessing every patient and not just assuming that they are hot, need to be cooled, and given fluids for dehydration. There could be other things going on.
This 49-year-old woman presents to the emergency department with the chief complaint of right ear pain. Hey, Donnie, can you do something about that?
What?
Seriously, that's not driving you nuts? The baby, it won't stop crying.
Oh, that music's my ears now. I think Jesse's the nurse.
Well, can't you... What the hell is going on?
With what?
With her. Can you make her stop crying?
She's been fed and changed. She's cranky from rhinovirus.
Isn't there something you can do?
She's due for her next Tylenol. Give me a minute. I'll be right back.
Wait, no, I'm not gonna stay here. What is your problem? That's precisely why I didn't go into peds.
EM's not a great choice either if you don't like babies, because we treat the full spectrum of ages from babies that were just born to the end of life. And they're honestly some of the scariest to treat because they can't talk to us. You have to be very thorough with your exams and workups. And you have to know how to try and calm them down. Another thing about Santos's charts, she doesn't use any templates. She's just going from a blank document for each one of these. And we use a lot of templates in our department to make documentation a lot quicker. Usually my template will start with it'll auto-populate the name, age, and the gender from the chart. And then I will document the HPI from there. The vitals will auto blow in, and then I have a templated physical exam that I will fill out, and then my MDM at the bottom. And it's already like structured, ready to go. Going from a blank page is definitely slowing her down and why she's so far behind on her charts.
Plan?
I'll have Mel and Langdon suture up the lacerations.
Wait, what? That could take days. I
Calm
really...
down, Sadness. I'm kidding. This is one for my skilled surgical residents upstairs, not you Boy Scout butchers.
Boy, I missed you, Yo-Yo.
Can't say the same. Okay, let's take up this art project.
Although lac repairs are one of the more simple procedures we do and one that I enjoy a lot, very complex lac repairs, like the ones that are going to be required in this case, are much better suited for a surgeon, potentially in the OR, but definitely under sedation. And tying up a resident to do a suture repair, which literally could take hours, is not a good use of resources down in the department.
How is everything at home with you and Whitaker?
He's weirder than you'd expect. Yeah, but I don't see him all that much. He spends a lot of time at Amy's.
He has a girlfriend?
I don't know what to call it. The farmer who got burned last year, the day of the mass cache, his widow, Amy.
Oh, he died?
Yeah, he had burns on 90% of his body. His chance of survival was very slim.
Okay, so I'm an optimist.
The sun doesn't always come out tomorrow, Annie.
Wait, wasn't she pregnant?
No, she was a young orphan.
No, not Annie, Amy.
Yes, very pregnant and young.
And Whitaker's now seeing this Amy?
And her baby. He got really close to the family when the husband was dying. He really believed that the guy would pull through. He helped her through the loss of her husband, and then again when she had the kid, and now he spends almost every weekend at the farm.
Huh.
Plus he's on the street team, and he just wants to help everybody, and I just don't want to see him taken advantage of. You know, he's just a fucking huckleberry.
Yeah, but he's our fucking Huckleberry. I'll talk to him.
Hey, your call.
Strong deflection, well played.
You're the boss.
It's important to have hobbies and things that you like to engage in outside of the hospital, but hearing all of that, I would definitely be concerned for Whitaker's mental health and wellness, because he seems to be doing his job all the time and taking no breaks for himself. He might enjoy some of those things, but I mean, it really sounds like he needs to take a break once in a while.
Now slide your bottom down. Yeah, a little bit more. A little more.
Sorry, I can't.
Okay, it's okay. We can take a break. No problem.
I don't want to break. I want to stop.
Okay. Is this about reporting? Because you can do this collection without a police report for now, and none of it goes in your permanent medical record.
I don't want to do this anymore.
Tell me why you want to stop.
He's my friend. He knows all my friends. It was just a dumb... He was drunk. He didn't mean... It didn't mean anything.
Okay. Okay. It's okay, I understand. Me too. A lot of... This is a difficult process, to say the least. Why don't you take a breather and come back, and whatever you want to do, we'll do.
I think that Dana handled that very well. Obviously, these are very vulnerable situations, very tense situations typically, and it's quite frequent that the perpetrator of the assault is someone that the patient knows, and that makes things all that much more difficult from a psychosocial standpoint, from a trauma standpoint, and for life moving forward. And so I think that it's totally appropriate for her to take a break here, but it's good on Dana to support her, know that whatever decision she makes, she will be. We had a battery glitch, so I'm hoping that everything has saved. Let's continue.
Uh-oh, this can't be good.
Who's this?
That is hospital CEO Trent Norris. He's the big boss.
Nice outfit.
Hey, Rockstar, gather your staff, please.
Sure, anything you want to tell me first?
No.
Hey, everybody, can you gather around, listen up for a moment, please?
And have your attention, everyone. The internal disaster at Westbridge has been identified as a cyber attack. Our IT protection system has blocked thousands of intrusion attempts in the hours since Westbridge was hit this morning, but IT believes we're still vulnerable. So we're going to preemptively shut down all the computer systems. Patient registration, electronic health records, lab and radiology interfaces, email, internet.
Talk to me first. You want to consult my department?
I consulted your fellow attending.
When are we going down?
Soon. Very soon.
Okay, hey, somebody get a picture of the board. Quickly, quickly. We're about to go analog.
Phones work? They don't work.
You got the photo?
Yeah, I got it.
This is gonna be fun.
Well, that is definitely going to make things much more difficult in the emergency department. I mean, we rely on the EMR for everything that we do, and in this day and age, we are not trained on paper charts, paper orders, all of the analog systems that would be necessary in this situation as med students and residents that are being trained in the last, I don't even know when we transitioned, 20 years? Who knows? I'm excited to see what the next couple of episodes bring because this is a twist that I wasn't expecting. We do have downtime in the department at times, but typically our Epic is frozen. Epic is just the EMR that we use, and it gets frozen for updates. And while it's frozen, we can still make orders, look at people's charts, things like that. We just can't make certain modifications like developing new order sets for ourselves and smart phrases. It's a lot of like the customization things that we can't change during these downtimes for upgrades, but most of the functionality like placing orders and registering patients, things like that are still available. So losing all of that, I guess we'll find out in the next episode. We'll catch you in the next one.